Thanks, Deepak, and good morning to everybody. How many of you right now are actively dealing with toxicology in the intensive care settings? Raise your hands, please. अच्छी तरह से करो यार, दिख नहीं रहा लाइट में. Maybe around 1/3. How many of you are actually from MD from internal medicine? Very small percentage. And MD respiratory medicine? And anesthesia, I presume, are the rest of the people. And again, the next question is, how many of you are working in a teaching medical school, in a medical schools? And how many of you are in the corporate hospitals? Oh, great, a big number. I think that's probably, I was looking at it, and quite a few number of, in medical schools, by and large, it is Department of Anesthesiology which looks after critical care, and toxicology dominant work is looked after by internal medicine. Am I right or wrong? And then obviously a small percent of the patients which gets shifted to your intensive care, you come in it, and most of the time it's a reflex with which you are treating up, and you keep on calling the medical people back for your help. Am I right or wrong? And the pattern which we see in poisoning will be very different. What you will see in a government tertiary care hospitals like ours, vis-a-vis what you will see sometimes in corporate hospitals, especially in South Delhi, or if somebody is from Mumbai or from Calcutta or from Bangalore, where you will see more and more incidents of drugs in terms of opioids, in terms of sedatives, etc. is there. And the part is that we are dealing with a huge agrarian crisis in this country. Probably I don't know how much of you are aware about it, but nevertheless, what is important is when you talk in terms of toxicology, always remember what Paracelsus says, dose makes the poison. That means any substance which may not be, which is innoxious, which may be helpful, but if you see and take it beyond the limit, and one of the classical examples is a paracetamol. If you take it up to 4 to 6 grams, it is pretty good in terms of relieving pain, in terms of fever, but the moment you start crossing about 8 grams or so, it can be toxic. Similar could be a problem for that, like insulin, the way we use it, or any other drug, whichever we are using it. And when you look at it, most of the time people do or commit or take substances for self-harm when they are under depression, or it's a knee-jerk reaction, or sometimes it's a very impulsive desire, unless or until have a depression. But most of the time, whatever is available to them, they take it. So one has seen practically everything which is available to the person at the time of the thought or the decision to be taken to cause self-harm. Whatever is available, they take it up. And similarly, toxicology, another very interesting aspect, if you look at the mythology, the history has been used for time immemorials to kill people or to do a sabotage or espionage. So it's a very interesting sign. And when you talk in terms of agrarian crisis, the people you are coming, the farmers, you will see, they can have an availability of insecticides, they can have an availability of herbicides, they can also have an availability not only of these things but also insecticides. So when you see it from the broader perspective, and which we see, being we are sitting in the right in the heart of Haryana, and I'm certain other medical schools also, we see large amount of poisonings which are coming to us actually belong to that rural or even in the urban group, depending upon the places. But predominantly what we are seeing is either insecticides, herbicides, or your pesticides. And sulphosphorus used to be number one, along with organophosphorus. There has been a gradual shift from copper sulfate in mid-70s, barbiturates in the late 70s, to aluminum phosphide. But the carbon organophosphates has kept a reasonable number, and usually in terms of intensive care admissions, they continue to be the commonest poisoning in majority of the centers. Sulfurous poisoning, we are seeing a decline because of change of packages. So with this background, let's start and look at organophosphorus poisoning. Let's look at a case scenario. Is it visible till the end? Any question, any doubt, raise your hand and get up and ask me, okay? And what you are seeing, it's a 48-year-old housewife, had no comorbidities, was brought to emergency with a profound sweating, excessive salivation, diarrhea, breathlessness for 2 hours after consuming some substance. When we examine the patient, person has a pulse rate of 52 per minute, has a hypotension, marked tachypnea, and also pulse oximetry showed significant hypoxemia on room air without any elevation of JVP, or there is no evidence of cardiac failure. Chest has got a bilateral extensive crepitations. CVS examination was, on auscultation was normal, and when we looked at it, pupils were pinpoint and they were not reacting to light. This is not an uncommon thing which you see if you have been posted to accident and emergency. Now the question comes that how are we going to approach this case, and that will highlight over next 20 to 30 minutes what we are going to discuss. So how are we going to approach this case? If somebody comes and you're sitting in an A&D, or you have been called by an A&D resident, how will you proceed? Anybody? A, B, C, D. That is fair enough. So what you are trying to do by A, B, C, D? You are trying to resuscitate and keep the patient alive, one. But at the same time, you will also look at an emergency, like a computer, what is the cause for this? So your aims are to evaluate the patient, know the cause, and at the same time, you need to see that the patient stays alive so that it gives you a time to act. That is important. So you are doing three things together. A, you are assessing. Second, you are processing. And third, you are acting on that way. And obviously, in any scenario when you have an emergency medicine or whenever you are in critical care, you always look at airway, breathing, circulation, and then depending upon that you can have a drugs, detoxification, and toxicology. It comes the elimination and so on and so forth. So you remember that way, and I very right. And then let's look at it, what we are going to do. So what we did in this patient was, as you said, we look at in a history, and one of our patient's relatives showed us the photograph of it, which showed monosome, and this is called as monocrotophos. This is the trade name which is there. Therefore, it is a good practice when you are looking at it that a person practically is bleeding, is actually leaking from everywhere, and along with it, you are finding a signs of autonomic dysfunction, and which is having a cholinergic excess, and that is what you call as a syndromic approach in poisoning. So obviously you start thinking in terms of that there is a cholinergic excess, and what is the cause of this cholinergic excess. And in our clinical practice, the commonest is your organophosphate poisoning. That's what we look at it. Therefore, when you see this patient very clearly tells us from the history and with the availability of the photograph that it is nothing else but what we are dealing is with an organophosphate toxicity or organophosphate poisoning. And in this case, you need to look at it. There could be two components which can come to you. Either person has taken a carbamate or person has taken an organophosphorus or organophosphate compound. What is the carbamate classical which you see in the homes? Which is there? Pardon? Begon. Begon was the classical example which is there, and it is important to note that there are certain theoretical differences, and there is also maybe certain approaches may be similar, but in terms of outcome there could be a difference. So let's look at it. Now you have organophosphorus compounds, and this is a carbamate. You see to it that there is a difference in the basic ring which is there, and obviously if you are replacing this oxygen with it, then the compounds changes, and what you find out is by the moving of oxygen, this becomes a nerve agent which is ultra short acting and have been used in Second World War, and also subsequently have been used in Iraq and other places. So this is the agent for the chemical warfare which we see, tabin, sarin, etc. That's what you look at it. Whereas in a carbamate, you will see there is a compound which is a nitrous ring, which is totally different from it. So therefore, what is very important to realize is that the toxicity is much higher with the organophosphorus compound vis-a-vis carbamate. So with the same amount of an ingestion, you will have severity much more with, which were much more with organophosphates. Good. And then obviously duration and action for organophosphorus compound is going to be much longer than your carbamates. And obviously CNS toxicity is far more common. Why it is more common? Because they are able to cross the blood-brain barrier and they go up there. Not only that, and what is because they are lipophilic, majority of them. So therefore they tend to go up, and depending upon the compound, you can have a peripheral action, you can have central action. Now let's look at it, what they are. These are the components of nerve gas which I showed you, that when you've taken away the oxygenation component, what you are seeing is actually a nerve agent. And annually, this is what is the data which was in 2005. It's over a year, it's not much difference, but yes, insecticide class 3 have been removed from the West, which we still continue to use it, and estimated nearly you are dying, 3 lakh people everywhere in the world are dying because of this. So when you start looking at an organophosphorus count, this is a global picture. But let's look at it, what is happening in us. It is one of the commonest poisoning across the country. It may be regional differences. In North, we were seeing much more. In the grains, especially the wheat growing area, we were seeing much more commonly. That is aluminum phosphide. It is showing now a decline because of the hue and cry and changes in packaging. But what we are seeing is that constantly it is there, and in these cases accounted for nearly 50% of all the organophosphate compounds, and in intensive care it continues to be the commonest cause of poisoning which is there, and majority are suicidal intent. So whenever you look at these things, it can be suicidal, it could be accidental, or it can be, in these cases, it can be a deliberate or a homicidal intent. But remember one thing, you must have read that at certain place in Bihar, they had gone to a party, or other places by default, somebody was thought that organophosphorus is a wheat flour, and they mixed it up, and a large number of children, they died around about a couple of years ago. So it is very important. That was an unintentional accidental poisoning which was there, and most of the time what we are seeing is actually in these patients which are coming to us are suicidal, and the amount therefore being consumed is much higher. Whereas in accidental, like for the farmers when they are doing spraying it in their farms, is little different. That is not as severe. It is severe but not as severe, as not long lasting as you see in cases of suicidal. People will come, they've taken 100 ml, 200 ml depending upon the package which is available. And that is why you will see whatever the books have written, it falls flat on the face. For that simple reason, because large amount is taken up, and because they are lipophilic, they go and get stored in the fat, and when you think patient is doing, it starts coming back out, and therefore continuing with the symptoms for more than a week to 10 days, which is not described usually in the Western books. Therefore, it is important to realize how much person has taken, and therefore, thereafter, you need to look at it, the substance which is there, and how much it is duration which is expected to take place for it to clear off. This is our data. This is a thesis which we had done it. What we found out of the total admissions which we are having in our hospital at that point was around about nearly, we had 50,000 plus admissions in the hospital in 2009, and what you said, 92% had taken it by oral route, and what we found was 1.2% of the total cases admitted was suspected poisoning. Each year we get around 1200 to 1400 cases. This is a part of a forensic medicine thesis. I was the co-supervisor, and we found out that only 7% by inhalation route, that was an accidental in the forming. 65%, two-thirds was suicidal intent. 30%, as people said, accidental. We have a doubt about it though. And obviously 4% were homicidal, that somebody come put it in the water, etc. So all that stuff, it is going to be there. And 70% was reported mortality with aluminum phosphide, and 34% was there in organophosphates. So it is important to realize is that even when patient reaches to you, it still continues to have a significant mortality and morbidity. Is it clear or not? This is one institution data which I am giving it to you. This was our data which we had observed, and what we found, 134 patients over a period of a 1 year and 15 months were there. and 85% were put on mechanical ventilator. 36 patients, they expired. Most of the patients who are coming to you already have been coming from outside, and major cause of death is not OP per se, but the associated complications which takes place. And one of the worst complications which take place in this actually is an aspiration pneumonia and accident and emergency, the way the lavages are done, A. And secondly, the underreporting or underplaying of cardiac toxicity. I think that is what you need to know. And mechanism of toxicity, you should know it. What is happening is an acetylcholine signaling at the synapse. Whenever an electrical thing does, it gets converted into chemical, and the presynapse ACH is released. They are the receptors. They lead to activation. That is what happens. Obviously, well, this is a normal activity. Now, if you don't stop it, it will go uninhibition. This is called as depolarization. And on the basis of that, you will see the electrical impulse will come. And now, obviously, what we are seeing here is this is blocked by the acetylcholine esterase enzyme. Therefore, that takes it away, that squenches it away and regenerates it so that the action stops. But what happens in OP and a carbamate is it blocks this enzyme, and this action, there is an ACH access at the postsynapse. The net result is continuous bombardment, and there is a depolarizing block. And hence, as a result of it, depending upon it, what it has stimulated, you will have a combination of symptoms which are going to be there. And that's what we look at it. Again, you can have two sites where it acts primarily, nicotinic or muscarinic, and third is a CNS effect. And you see it throughout wherever the nerve impulses are conducted. The end target, depending upon it, could be either acetylcholine or norepinephrine. If it is a sympathetic, end result will be at the postsynaptics synapse will be norepinephrine in sympathetic, postganglionic, whereas as far as your parasympathetic or otherwise is concerned is going to be acetylcholine. And at the presynaptic level, at all the levels, it is going to be acetylcholine. Is it clear or not? That is why you have a variability of symptom complex depending upon where this is acting more. And hence what you see is the nicotinic site. One of the classical clinical site is fasciculations. Anybody who has a fasciculation, that is a which effect? That is a nicotinic effect. That is a nicotinic effect. On the other hand, the so-called sludge, pouring of every single hole of the body, every body portion, that comes up under the gland. And then you have a meiosis, you have a killer bees, you should remember, is a bronchoconstriction and a bronchospasm. And along with it, when it works on the heart, it can cause bradycardia, it can cause torsade, it can cause your sudden cardiac death, etc. 50% of the deaths which are taking place before patient reaches hospital is either cardiac or cardiorespiratory. That is very important because it affects on the CO2 depolarization. And this is a nicotinic, what we have been taught classically here. It is the PAM which acts, and it is the muscarinic site, it is the atropine which is acting. But it is equally important is the CNS effect. PAM doesn't cross. If anything, it is there where the ACH synapses are there, which usually extrapyramidal or to the reticular activating system. So you will see the seizures, altered sensorium are the common effects which are there, and it is only the atropine which can cross, or other anticholinergics which can cross, can be used in the CNS effect of management. As well as if seizures are there, you need to inhibit those seizures, and that is where the GABA inhibitors or GABA agonists, which like you are having a diazepam, that becomes an important thing which works through the GABA. They are important, the channels which are there. So simple thing you should remember is the summary of it is that steric inhibition of acetylcholinesterases, excess of HH receptor, and muscarinic and nicotinic effect along with central effect decides the total toxidrome of OP toxicity. Is it clear? This is a summary of it, and obviously it is defined as an acute cholinergic syndrome, and what you see is a peripheral effect, central effect. And the peripheral will be muscarinic and nicotinic, and that is all you need to know, and you can work out further. But the key difference in the nicotinic and muscarinic is that the muscarinic are relatively slower to act. It can again be an excitatory or inhibitory. Inhibitory, like in the heart, it will lead to bradycardia. Excitatory, it will lead to the glands, where you will have a salivation, you have a bronchoria, you can have a diarrhea, you can have a emesis, you can have a urination. Isn't it or not? So that part we need to do it and we need to look at it. And obviously the muscarinic does not affect skeletal muscles, and they are predominantly what you are seeing are a nicotinic effect. And but again, as I said, this is what decides what is excitatory and inhibitory, and that is what is a simple thing. You can take it up. Nicotinic and muscarinic effect, it is there. CNS, it is there. These are the preganglions which are active, both places acetylcholine, and depending upon it, whether you are looking at a sympathetic, there will be that is a norepinephrine excess. So norepinephrine के साथ क्या होगा? Adrenergic के साथ क्या होगा? You will have hypertension. You will have tachycardia. Even if it is too large a thing, sometimes in a very small percentage of cases, instead of meiosis, you may have mydriasis. So mydriasis, though, is an exception than a rule, but nevertheless, you should look at it. If you are finding it, somebody has taken up. So all these things tell you a nicotinic excess because of postsynaptic noradrenergic receptors which are dominating at that point of time. Is it clear or not? Rest other persons, you will see it. Muscarinic effects could be diaphoresis, etc. And these are the cardiac effects. You can have bradycardia, prolonged QRST, ventricular arrhythmia, torsade, etc. Cardiac block, cardiac arrest. So it is very important for us to realize it. So when you are using atropine, see to it, person has been properly oxygenated. And most of you coming from anesthesia, sometimes in some number of patients, sometimes atropine can have a paradoxic effect and cause cardiac arrest, especially if somebody is having a hypoxemia and secretion, and it may stimulate or cause ventricular fibrillation. Is it or not? And sometimes it can also straight away can lead to complete damage to the. So very widely in the lipid solubility, I talked to you about it. If you see the lipophilic insecticides, is important to know that relatively minor early clinical feature. One of the classical example is a forate. And they tend to have an apnea, person sitting there, and suddenly you find not minimum side effect, which comes by the name chai patti. They are the ones flakes which are there. And you will see certain person has an apnea. So they can have a delayed effect, which is there, which is important. And you think person is all right, you try to take them on ventilators, again they go into it. So recurrence of toxicity is much more common, and delayed respiratory failure is not an uncommon thing. And obviously duration going to be much larger. Now, how do you investigate? That's what we look at it. We look at classical ABG electrolytes, ECG, chest X-ray, and we look at the cholinesterase levels. This is how we do it. In this cases, when you look at it, the books write commonly we do serum cholinesterase, ideally is an RBC cholinesterases. But they are most of the time not available, need to do with an HPLC. But it is important for us that we can do it and we continue to follow. If you find that your cholinesterase levels are less than 50%, the diagnosis by and large is certain. If you are not having that bottle or the substance form is with you. So you very rightly said treatment strategies. You have an A, B, C, D, airway, breathing, circulation, and obviously detoxification and the drug. This is the way we go forward in this patient. So you maintain airway, you do breathing, you do circulation, and obviously along with you have the drugs, detoxification. For detoxification, you can either have decreased absorption or increase elimination. This is how the poisoning works. And then obviously the drugs you do, antidote which are atropine or anticholinergics. For the cholinergic it is anticholinergics, and you also try to reactivate at the cellular level, that is you try to give them ralidoxin, and let's see what it says. So initial should be directed, as we very rightly said, we stabilize cardiovascular function by reversing excessive muscarinic effect. That is the most effective way in which to do. Now what we did in this patient was we did volume resuscitation with crystalloid, right or wrong. Then she was intubated and put on mechanical ventilation. So what did we take care of? No scoline. No scoline. Because scoline also going to create the same thing, it causes depolarizing block. So most important thing is you will not use any depolarizing agent. If you need to do it, then it is non-depolarizing ones. Curares, that's what we look at it, pancuronium, vicurinium, etc. Not otherwise. Due to competitive inhibition, increased doses of non-depolarizing neuroblocker may be required because you are having a competition. So if you need to do it, you may be needing more dose than what is average required. First, you should not. We usually do with under sedation and this thing, but still if it is required, then it is a non-depolarizing, and there's a competition, and then you need to maybe using hydrogen. Is it clear now? These are practical practice points. And obviously, this is what we looked at and what we did it. Atropine, obviously it competitive antagonist of acetylcholinesterase, cholinergic antidote, anticholinergic. Or anticholinergic antidote, cholinergic you use neostigmine. Yes or no? When you have an excess atropine or you want to reverse the mixtures which you use during causing muscle relaxation, don't you use in theaters? So what is important? Cholinergic antidote, anticholinergic antidote, cholinergics. This is how we work. And obviously, there's so many regimes. What we practically follow is each ampule of atropine contains how much milligram of atropine? 0.5 or 0.6. That's what we look at it. So that means you start with 2 ampules straight away. Stack. You oxygenate. You start this thing, and you keep on doubling the dose every 5 minutes. I have seen and recall using up to 700 of these vials in the first 24 hours. Now, things have changed over a period of time. When we were residents in late 80s, this is what we used to practice, early 90s. So, after initial loading, atropine should be continued preferably as an infusion. What you do is how you decide 10 to 20%. What you look at it, let's say I have given 100 milligrams of it. So, I will calculate in, let's say in 12 hours, I have given 100 milligrams. Or 6 hours I have given it. I will continue catch of the time duration. I will take 10 to 20%, which makes adequate cardiac respiratory rate, keep the lung dry. That is my target. Not looking at tachycardia, not looking at mydriasis. Because why I am giving, I want to see that the heart works properly at a proper rate and there are no secretion, so oxygenation is not a problem. Is it clear enough? This is how we work out. So the therapeutic endpoint is respiratory secretions and cessation of bronchoconstriction. That's what we all look at it. That's it. And along with it, we try to keep heart rate if bradycardia is there around 90 plus. Not 120, 130. Why we do so? To prevent anticholinergic syndrome, atropine toxicity. That is important. So people look at tachycardia, people look at mydriasis. No, that is not required. Is it clear now? So don't look at it. Keep heart rate above 90. Keep lungs dry. When lungs will be dry, bronchoconstriction will also disappear. That means along with secretion, it has blocked the action of cholinergics on the bronchus. That's what is important. Now this was one of the trials on the basis published in Journal of Medical Toxicology. It was an open label trial on the basis of which they give intermittent on one group and infusion on the other side. I will not go into the details of that. And what did they find? The doubling dose regime resulted in 84 reduction in the mean time to atropinization and fall in case fatality from 22 to 8%. And reduction on the proportion of patients showing toxicity also decreased by more than 50%. That means I started it to, I double it up. After I adequately reach those targets, I shifted over to infusion. That's what we need to do. And a common mistake which happens in ICU is when your syringe of insulin, of your atropine finishes, then the sister goes, and again you realize it takes another couple of minutes, and the person is in a bradycardia, and you come in the round, sir, there was a bradycardia, we try to do it, and they say, what bloody nonsense. It has to be taken care of. It's quite happening when the new residents come or new staff nurses come, or when the staff nurses become too senior. They take things like that. Please, when you find it is going to go up in half an hour or so or 1 hour, please be ready with the new syringe. That's a common practical mistake which is done, and again it is a big setback which happens to the patient. This is what you need to look at it. And obviously, watch the patient for the recurrent cholinergic toxicity or onset of atropine toxicity. Have you seen persons they're agitating, fighting, somebody comes, they were doing like this, they're hallucinating because of atropine toxicity. They will be warm. And you remember now the Dhatura toxicity. What is happening? They will be agitated, they will be hallucinating, they will be dry, they will be high fever. You put your hand in their armpits, they will be absolutely dry. Skin will be dry, hot flush. That's the cholinergic, anticholinergic syndrome. Please don't do that. Sometimes they take out their catheters, they do it, and they become a nursing challenge. And what you do at that point of time, haloperidol, or you give a propofol, or you give a fentanyl. Isn't it? This is what happens. Don't allow that thing to happen. You have created another problem. So please see to it, do not overzealously treat with the atropine. Just keep it at a minimum which is required to keep symptoms under check. That is important, which you should remember. Now, glycopyrronium bromide, my friends come up, they do it. When we have an atropine toxicity, we do shift it to it, but it's a expensive drug, and there is another problem. Anybody can tell me, can it cross CNS or not? No. So if somebody has a CNS function, it is of no good use. And now J.D. Peter and group has described, we were used to wonder what is happening third, fourth day sometime. Few patients will go into deep slumber. Yes or no? We say, sir, it's a brain dead, not responding for an. But what we realize today is, it is the uninhibited action or a dominant central nervous action. Because of low dose of atropine, it has recurred. So what you do there? We use atropine, we don't use your glycopyrronium and also another drug which is used in Parkinsonism, anticholinergic, pacitate, trichlorhexidine. That's what we use. And it does work. Therefore, if somebody after initial recovery has gone back and has become an unconscious, don't be paralyzed. Wait, it will take 3 to 4 days before patient will come back. And if you have given large amount of sedation, do a BIS entropy, you will come to know how much sedation is there or not in your ICUs. Oximes is important. We know that usually the acetylcholinesterase recovers. A concept which has happened is called as an aging if you add water there. So hydrolysis if water is added here. So what is the two components? This is an oxygen, this is an organophosphate compound, this is a covalent bond. Now here the water occurs. If the aging occurs, then the PAM doesn't work. So you trying to retake it out of the, it's like a amalgamation. It's like you trying to take out the metal out of the ores. It's something like that you have put into it here, and they have attached to ester, but bonding has not aged. So when this covalent bonding which is happening doesn't age, that means then it can be hydrolysis if it is there, and you can bring the ACH back. So acetylcholinesterase quenches it, comes out and regenerates and stop that one. But here what you see is it blocks the action of acetylcholinesterase. So you want it to be re-put into action so that it is not aging. This is an age enzyme, bond gets strengthened and there will be no hydrolysis. So it is important for us to see that more acetylcholinesterase becomes available so that cholinesterase is there. In addition, we see there occurs changes in ACH receptors both at the level of the postsynapse, which also needs a new formation of ACH receptor, and hence you see a longer time duration. So this is how the PAM works. Electropositive nitrogen or 2-PAM is to the electronegative anionic side. So positive, negative, male, female are combining together, and that is what it is neutralizing and leading on to regeneration. Theoretical, there is nothing wrong with it, but practically let's see what is happening. And obviously what we are finding is compounds coming into two groups. What we look at is dimethoxy or diethoxy. Now methoxy has a shorter half-life time like malathion, etc. So it is found that it is not very effective because you have a very small window to act. On the diethoxy it can up to 33 hours or 36 hours. So you have a longer window you can act. So it is important from the perspective of a critical care and emergency physician to know in how much time duration is there between what person has taken and what it is happening. But when it is lipophilic, it gets released. It again gives you a window of opportunity to act with PAM. That's important. Now there is a huge controversy about the use of PAM. What you should remember, this is a WHO dose. You give it 30 mg per kg in the adults, and then you administer it slowly over 30 minutes, and then obviously you continue infusion 8 mg per kilogram, 10 to 20 mg for children. What is important is that certain articles write that if this dose doesn't act, you probably repeat after, let's say, another half an hour or so. I have not used it and I usually do not recommend it because what has made the huge difference in outcome is atropine plus mechanical ventilation. That is important, but nevertheless, because of legal issues people have and the type of pattern and training, it becomes difficult to rewrite it. Now that is what is happening. The data clearly shows it up that it is not helping out. Utility of PAM for acute toxicity or systemic review. Effectiveness of PAM for preventing death is poison patients. It is negative. If it would have been there, it would have been positive. Same thing we are finding is there are another data which are showing it up for intubation. It is not making much of a difference. Similarly, intubation, again, it's a plus minus thing. You may use, you may not use. The papers have been published by Kirti Pawar and also in Lancet, where they say moderate cases it helps, severe cases may not, because there could be additional factors for toxicity, especially majority died what the data comes up with, either a cardiac or respiratory. That's what it shows. So it is still unclear whether this is a group who will benefit clinically from pralidoxime administration, but sick patients should receive in a critical care environment with full support of airway and ventilation plus atropine titrated doses. What is if somebody has a tachycardia, somebody has a hypertension, has a huge fasciculation, it's worthwhile using a PAM. If it is not, or carbamates are there, there is no idea of using it. So you have to decide case to case basis rather than blanketly, yes, I need to give it, I don't need to give it. Is it clear? So that is important part to remember. So contaminated clothes, etc., this is much more relevant. Please be very careful about it. Don't use the simple gloves. Rubber gloves are better one. And when you are doing it, and always take precaution, much more in accidental than what we see. Activated charcoal, people have tried to prevent the absorption. Now we standard practice, we do it. Dr. Richeria or Vivekanshus are not around, but nevertheless it is still recommended, but data is very plus minus, doesn't much too much. Benzodiazepine are the drug of choice if somebody has got seizures, because it works through, it causes GABA agonist or antagonist. What is Joseph Bolo? Antagonist, right. Now magnesium again has been recommended. It's a GABA agonist. It's an agonist. It's an inhibitor. It causes inhibition, so it stimulates that way. So it's something we were talking about the fake news. I said when you were examining the paper, 10 people written the wrong thing, you start writing, "Main theek hu ya ye theek hai." So you go back. So I asked you. All right. But nevertheless, it's a GABA. It stimulates GABA activity. Actually, that's what it does. So that is an agonist act. And that is what people have seen in 90s, but not much has been done. But magnesium, they are saying it that you up to 4 grams can be effective. I have no experience, but nevertheless, this has been recommended because most of them are very comfortable using what I have discussed with ventilation. So we have never tried for it. But the data says it does help. Impact of, obviously, that is again showing a positivity of the outcomes, and this is the clinical toxicology result which is coming up and saying probably time has come for us to start looking at it. Probably it can take care of arrhythmias. It counteracts your calcium, sodium ATPase channel. It acts against the calcium homeostasis. Probably that can also help us in the repolarization defects which are there. And I said one of the important cause of death is cardiac, not only respiratory. So might be working at that level for us to help. Lipid emulsion, people have tried, it's a lipid soluble, let's do it. Data has come up, but the analysis shows it is of no good use. Sodium bicarbonate, people have tried, discussed, we do not recommend. We do not recommend. The data is again not favor of it. Now, alkalization, people look at it. Well-designed control trial means data is not in favor. Na aap haan keh rahe, na keh rahe, beech mein phase hue hain. But the idea is we should not. Unless until you have sometimes you have a combination of organophosphates with other compounds which are highly metabolically can be removed. There's a small group of poisons which are there, but not in a pure OP poisoning. We do not recommend. Case continues. She extubated. After 2 days, on 3rd day, she became breathless. Have you seen these cases? They improve when they become breathless. On examination, poor neck holding, extraocular muscle weakness was observed, weakness of proximal muscle, she was not able to raise her hand, and deep tender reflexes happened. What happened? Intermediate syndrome. So that is what is important. That's what we need to look at. So ask the person every day, raise your hand, raise your neck, raise your legs, look at eyes. What is the classical description of this thing? And ocular crisis, which can happen in these cases, or you can have extraocular muscles. So this is a delayed onset of muscular weakness and paralysis. That is what happens. Because why it was called intermediate, early तो आपने देख लिया, late आपका न्यूरोपैथी होगी तो बीच में फंस गया इसलिए intermediate बोल दिया. That's how it was described by Sen and Naik in 1991, and R.S. Wadia from Pune described the neuromuscular dysfunction, nerve conduction abnormalities, and also called as type 2 respiratory failure or type 2 blocks which are happening in these patients. So when they look at nerve conduction, they have type 1, type 2, this fits with type 2. That is what we look neurologically in terms of conduction. And this is a major contributor to death associated with respiratory failure, because we feel nothing will happen, shift the patient to the ward, nobody is there to look after the airway, and medicine residents are the best in managing airway, not the anesthetist, isn't it? That's how it happens, and suddenly they will be calling Frank and everywhere, code blue, code blue. Sir, abhi to theek tha, pata nahi kya mujhe. No patient dies. So I think that is very important for us to realize. And susceptible need close observation and monitoring. I think that is very, very important for us to remember. Can we predict intermediate syndrome? The risk you will see elderly, but because we take large amount, so that could be there. Persons who have been having unconsciousness, and if you have they have a certain data to look at the severity scores, but what you see is a person is a severe muscular dysfunction to begin with, and certain compounds like monocrotophos, you have a dichlorvos, or you have phorate, they have much more chances of having it with it. And severe and prolonged inhibition, that means severity is the one which decides, and what could be the factors which is there. And in this case, we should not depend upon creatinine kinase or ASRT, but what is important is that single fiber electromyography, it is there. We are trying to use strain of 4, which you use it, but not very successful. That is what is there. You can do repetitive nerve stimulation, decremental incremental, that precedes IMS. So we tried to thought that at the bedside, can we do train of 4? And we did find they were not responding as much, but we were not able to reach conclusively a program. So mechanisms are different. What we feel is you are giving atropine, uninhibited muscular function is going on. That may be one responsible. So there is a down regulation of ACH receptors, persistent ACH inhibition, and again recurrence which is coming out in the gastric fluids, muscle fiber necrosis, desensitization of postsynaptic receptors, failure of release, and oxidative stress related. They are different ones. I have given a very simple theory to it. You use atropine, you stop pralidoxin. And now you have taken large amount, it keeps on knocking, and the muscle paralysis is secondary to nicotinic effect. And we also know today, Clinicarde and Sen and Naik again shown it, transformation of ACH receptors because of consistent binding in muscles took place nowhere else. So it is important is that whether pralidoxim has caused it or whether they may cause it, which is responsible, we still don't know. But there is a significant uninhibited nicotinic effect which is responsible for this. And this is a diagram, a cartoon which shows what I discussed with you. And in this, persistent excess depolarization, and this is happening in these patients and leading on ultimately to the muscle fiber necrosis and weakness. PAM, there is some incidence, some sports say that higher use of PAM may be associated with the intermediate syndrome. Now, after some time, she got re-intubated, atropine restarted, she had a VAP, tracheotomized, improved and decannulated. This is our patient, which we put it up later on. She recovered though, and another one is an OP-induced. I don't think that is related to it. We can tuck it out. So, my dear friends, science is the great antidote to the poison of fanaticism and superstition. I think that is very important for us to remember. Thank you very much. Any questions?
I have a question later on. We are running out of time.